Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again I'm so happy to have the chance to be with you all from this educational platform. And I have to say I'm so honored that so many great speakers from around the world accepted the invitation and are joining us every week from this platform and help us to increase the level of education and increase our knowledge and our knowings for better practice in our offices. And today, a very, very dear friend, a master clinician, and one of the leaders in the field of implant dentistry, Professor Patrick Palacci, is here with me. And I have to say, say hi to him, I'm so excited for this presentation today. Hello, Patrick, and welcome to Hot Seat, my friend.
Hello. Thank you.
Thank you for accepting the invitation. And I have to say, I think if you're a surgeon and if you're dealing with soft tissue and implant dentistry, definitely Dr. Palacci is one of the key opinion leaders in the field and one of those people that you are familiar with his work and with his leadership and whatever he taught us over the years. So today we have a great chance to learn from the master himself. And the topic that he will present for us actually is very, very interesting and very challenging, I believe, which is soft tissue manipulation and papilla recreation, the keys for success. Because as a periodontist, we all know that recreating papilla is one of the most concerning things that we face in our practice. So who can be better than Professor Patrick Palacci to learn from? So before we start, I would like to have a short CV of Dr. Palacci for all of you, and then we go to the presentation, and at the end, we will have a great discussion, as always, on the topic. Dr. Palacci graduated at the University of Marseille in 1975. He continued his postgrad education in periodontology at Boston University, United States, where he received the title of postgraduate. He was appointed consultant professor at Boston University in 1982. In 2004, he received the title of associate professor at the University of Santiago de Chile and the University of Buenos Aires in 2006. He maintains a private practice in Marseille. His center is one of the 12 Brandemark osseointegration centers in the world, working closely with Professor Pierre-Ingvar Brandemark. Dr. Palacci has developed many surgical techniques in relation to optimal implant positioning, plastic surgery techniques, and papilla regeneration. He is the author of numerous scientific articles written over the last 20 years in international journals. He is also the author of 2 books dealing with the aesthetic and implant treatment. These books have been written in English and published in 9 different languages. A 3rd book, in conjunction with the Technique Novel Guide, was written in 2008, jointly with Professor Peter Moy and Ingvar Eriksson, also translated into Japanese. He wrote, at the request of Professor Brandemark, a chapter on aesthetics and soft tissue management in the book From Calvanium to Calcanium, considered the Bible of implantology, and received Nobel Pharma Award in 1995 on the most important advances in surgery over the past 30 years. He currently provides many courses in his clinic in Marseille, advanced courses for experienced practitioners, groups from many countries like Sweden, Denmark, Chile, Italy, USA, Japan, Australia, New Zealand, and lots more, and could receive his teaching. He was invited and continues to give numerous lectures around the world. Once again, I'm so grateful to have Dr. Palacci on Hot Seat. So my friend, we are ready from head to toe for hearing your presentation. You can share your screen and we can enjoy your beautiful works.
Okay.
Yeah, it's perfect.
Share. Good. Okay?
Yeah, good.
Perfect. Okay. Dear Omid, thank you very much for your kind invitation. It's really a pleasure and honor to be with you today and try to share my experience in the field of implant dentistry. You just something in my presentation that I was giving courses all around the world. I say I used to give because now with COVID, I think everything is blocked. We don't know for how long. So it's Now, thank you for organizing this kind of meetings, because of people like you, we can continue to share and be passionate all together. We're going to discuss today on soft tissue manipulation. And you know that my philosophy has always been to be extremely simple, to try to simplify my treatments. It was my credo. And today, we have a very new situation with the COVID. And it's amazing to see that today, people change their lives. Everyone changed their life completely, totally. But some doctors, most of dentists, didn't change anything. They still continue to show extremely sophisticated surgeries with a lot of appointments, surgeries, re-entry. And this is not from today. This is something from the past. And I'm glad to show that my techniques with simplicity are absolutely related with this new situation. You will see that during this next hour. In our practice, we changed dramatically our practice. Of course, we were very safe, but now we have to be safer. The girls have to treat the air, the surfaces, as much as we can before each surgery. And we need not only to be on the safe side, because we don't want to be to contact this virus. And also, this is very important for our nurses, assistants, and for the patients, of course. So we need to be on a very safe side. It's what we do. So it's a little longer now. But you know, for me, it didn't change so much because I get more time by not being away. So now I have time to take more time for my patients. And this is what we get. So we have also to use all the technology to be simple. For example, an extraction may be perfectly extracted with the piezo surgery, and you can remove when you do immediate loading, which is a topic which could be a good topic also for a lecture, without any kind of damage. We need, if you want to play with immediate loading, with Ostel, to be on the safe side, because we didn't want to have failures. But now it's even more important not to have failures. And we used to be very safe all over the things, but we need now to be even better. Now even we get some helmets taking the air with some ventilation and purification of the air to be in a safe condition and to work in being more relaxed and not as we do. So we look as being a moon now, but this is extremely comfortable. And patients see that we are on the safe side. And the other thing is we shouldn't forget what we know and use all the technology we always used, because we get all these things to be on a safer borderline, that we forget all what we learned from the past years. And we're going to discuss about that. I was discussing today with Barbara Brenmark, the widow from PI, today, just 2 hours ago. And I said that I was telling that PI, who invented everything, was even ahead, because he said 25 years ago, when possible, one should avoid unnecessary, advanced and complicated major grafting procedures. And we saw that in the literature, in lectures, doctors mutilating the patients, taking big pieces of tissue from the palate of everywhere, and having 1, 2, 3, 4 surgeries to get nice connective tissue around the implants and show beautiful pictures. But what about the patient? What about the complication? What about the morbidity? We need to be simple. And to have reliable techniques, to have reliable work. Just an example to start. Look at this little girl. She knocked to my door, the door of my office 30 years ago, 1990. Young little girl. She had two missing lateral incisors, and she needed treatment. And she was very cute, and she was on the 20s, you see, 25, something like this. And she was a secretary, and she said, you know what? I'm going to take a loan, a credit to pay you. It's a big sacrifice for me, but I want the optimal results. And PI told us how to do that. We have to be simple. And you see, we started to understand that we started to give some space to this, to place 2 implants on this lateral incisor by orthodontic treatment. And after a few months, we could think about optimization of implant treatment. It means that one of the key factors, which I always spoke all these years, is precision in implant placement. Precision is related with the connection between the brain and the hand. You may have a good connection, or you may have 2 left hands, or you may have no brain. And if no connection, it will never work. And all the tools you may use are good. Some people may use no guide, surgical guide, guided surgery, whatever you want. But the only thing is to have the tool and the way to be precise. Being precise, we placed 2 basic implants, Brennemark implants, in those years. One side, we had enough bone. The other side, we have a concavity, and we took bone from the bone collector. We compacted this bone as much as we could to recreate the base for the soft tissue. Okay? At this time, we were doing big flaps, but people may tell that if you do a release incision, you have a scar, but that's not true. So if you do a bevel incision, you'll have no scar. But today, I don't open as I did now, except when I need. So I placed those 2 implants and closed it, and I placed 2 temporary crowns, Maryland Bridge there. And I was very happy with these temporary restorations, you see, because tissue for me looks nice, and I thought patient was extremely happy. And she was not. She came and said, look, I don't want that. So why? Look at the crowns are great. Say, okay, you have metal inside, this is normal. Yeah, but look, there is a concavity above the implants. Yeah, and look at the color. There is a shadow above the implants. I don't want that shadow. So she put the bar extremely high 30 years ago, where we just had the book from Brennemark and just placing implants to have dentures. And then a few months later, I went to do my Papilla Technique because I did my first case in 1988. Then I had 2 years, 3 years of experience with this technique. And I thought that was a really good thing, which is called the Palacci flap today, which is a pleasure. Someone told me in Chile, I remember, what do you feel about having your name on the technique? Nothing special, happy that people use it. But the thing is, I did this technique, and just to show you what we did 30 years ago, look, I asked the company at this time to do narrow healing abutments. It was they made a custom made, just they make 10 for me, and they say, oh, this guy is crazy, they didn't do anymore. But I was right, because today people are thinking about more space for soft tissue and less space for titanium. So 30 years ago, I knew that was a good idea. And then what did I do? I did my bevel incision, semilunar bevel incision, rotate the tissues and fill the space and create a mesial papilla. And then do the matrix suture, mesial, distal, above the papilla to maintain the tissue around this abutment. And imagine now if you have a wider abutment, you have no soft tissue, no blood supply, and it will be bye-bye aesthetic, bye-bye hygiene, bye-bye papilla, and then maybe bye-bye patient. And remember, she said, I want this to stay for a long time. This is what we did. You can see the 2 sequences. We're going to discuss about that in details, but this is a basic idea. It's crazy. One guy one day tell me, hi, I don't understand. This is so big, I don't understand why I didn't found this idea before you. Maybe I'm more stupid than other ones, but it worked and people are doing these tissues around the world now. And so far, no one has found a better technique. So we came from this case to this one 30 years ago. Not bad for a beginner. And we were now in what I call the class 1A. We're going to discuss about this classification, which is optimal situation with healthy papilla, over 50% of the papilla is there, and the is there. And by pushing the tissue labially, as I did, I could correct, without any connective tissue graft, the shape on these above these incisors. Look, no more shadow, no more concavity, everything is good. So I was really happy, and the patient was happy, because the aesthetic smile is related with the teeth, with the lip framework, and the gingival scaffold. And with a high lip line, high lip mobility, like this patient, young patient, you cannot afford to get two black triangles around each tooth. It would be a disaster for this patient. And the disaster, if you are not able to control it, it will stay forever. Because once you miss the technique, done, finito. Time goes, look at that. Extremely happy patient. I'm glad, but this is time 0, time 1 year. Time 0, 0 problems. And it's amazing to see that a lot of doctors show technique at time 0, and you don't know what's happened time. I'm going to show you what happens with this patient. 4 years later, look at that. We have some drifting of the lower teeth, look at that. But the implant is there, the papilla are healthy, everything is beautiful, and you don't know where is the implant. Then, patient, when she came, she got more mature. 12 years later, she's a mother of 2 daughters. She has still a high lip line. She's more mature, you see, woman. And you can see she still has this very happy with a smile. 20 years later, she still has the high lip line, high lip mobility, and the papilla there. 20 years, my friends. Who is showing 20 years papillas? And everything is still there, and the patient is extremely happy. But for her, it's normal. She said it's normal. No, she don't think she may have a problem. Time goes. She's now same patient 25 years later. Still high lip line, more wrinkles, but everything is still there. We can see on her eyes that she's extremely happy about the treatment. But then time goes. 30 years later, look at that, my friend. 30 years later, she's even better than she used to be 20 years later, 30 years before. We wish it could be available for everything for us. I think Omid and myself are not the same that we used to be 30 years before. But this is interesting to see that if you respect Mother Nature will be on your side. No fancy implants, no switching platform, no specific custom-made crowns. It was basic abutments, basic implants, nothing special. And you see the patient now, you see those 2 implants. People might discuss now about the bone loss around implants. And if you have not had the latest implant with the neck anatomy and everything, bone will be destroyed. Look at that. These are Serra 1 abutments on cemented restoration. And these abutments are from prehistorical story. Don't exist anymore. But it's still there in the patients. No bone loss at all in 30 years. And you see now the patient when she came, 1990, and it happened, happy patient, 2020. This is what we want to achieve, my friends, for our patients. And if we respect Mother Nature, if we don't change the technique every day, if we just build the pyramid, you see, carefully, we can achieve these kind of results. And we're going to discuss about that. Almost 20 years ago, when I wrote my second book, together with Ingvar from Gothenburg, we decided about an anterior maxilla classification to help the surgeons, the referring dentist, and even the patient to understand what would be the topic, what would be the challenge to treat this patient. Because when patients lose a tooth, a vertical loss every time. And the class 1 is an intact and healthy papilla. But then class 2, maybe a loss of more than 50% of the papilla. Class 3 being an extreme loss of the papilla. But you have an extreme loss of a papilla, you can understand that you will lose bone. And if you treat soft tissue by not treating bone, you will fail. Class 4 is no papilla, edentulous zone. This is extremely difficult. Sometimes it's flat with vertical height, but sometimes it's flat, but you lose a lot of bone. Then you need to have acrylic or prostate or ceramic papillas. But you know, you start to understand that the treatment and the treatment topics and objective will be different whether you are in class 1 or class 4. And this is extremely important, the treatment timing. Class A, together with the vertical, will have horizontal loss. 1A, no bone loss. It's extremely rare. But it's more amazing to see that a lot of lecturers show cases which are class 1A. So it's easy in a class 1A to get a good result. And they say, look, I was very good. I can have, because of this crown, because of my technique, because of my graft, because of my temporization, I got a good result. But you take a donkey, an animal, you put precise donkey and nice crowns, you got a success. The only thing is you can tell the patient that it's extremely difficult for them, for you, but you know you're in a class 1 and this is insurance. Class B, B2, you have a limited loss of the tissues. Then you can play with the soft tissue, okay? More than 50% of the papilla, limited loss of the buccal tissues, you need to play. But when you are in class 3C, you cannot play with just soft tissue, as I told you. You need to have a ridge reconstruction. To reconstruct a ridge, to have a solid base so that the tissue will cover that. And D, an extreme loss. These are dentures or case after accident where you need to reconstruct vertically, extremely difficult. So you start to understand what will be the topic and how many surgery you need. And patient has to understand that if you are in class 1A, maybe you can go to immediate loading or 2B. But if they are class D4, they cannot jump from 4 to 1A in one surgery. Impossible. And the referring dentist as well. So you have to understand that you need to climb the step gently. Today we are going to speak on class 1 and 2, 1A, 2B, because the course is for I say 1 year, but it can be 1 day or 2 days, you see. But I want you to understand the topic because I started 20 years, 30 years ago to give a lot of lectures of papillas. And I realized that the young people now have not seen me and don't know. They know the name, they know the technique, but they don't know how to do it. And if you just start to understand the basic, you can come back to your practice tomorrow and play with the tissues and create papillas and see that it works. It works all over the world. I hoped it just worked in Marseille because I could export water from Marseille and sell the water telling the papilla will grow. But if you understand, if you have a good connection between the brain and the hand, then the papilla will grow, whether you're in Tehran, in Los Angeles, or in Gothenburg, Marseille. So let's go back to class 1A. Class 1A, intact and healthy papilla. You lost a tooth not too long ago, you place an implant, and you know that if you place the implants perfectly well, the tissue will grow. And you have to understand that you don't need to do too much because every time, Froome, Tarnow, others have shown this, every time you can count on 2 millimeters from Mother Nature. It means that if you have a papilla at one level, after a few months, tissue will go down from 2 millimeters. This is a package you put aside. So if you're in a case like this, where you have a beginning of a start of a papilla, you know that just if you don't do anything, just put a beautiful crown, everything will grow. I want to be a little bit provocative because people say you have to play with the tissues and special abutments and everything, and you will help tissue to grow. But if you just place a normal crown with a basic anatomy, a nice anatomy, tissue will grow anywhere, anywhere, anyway. Because look at this case. 1 year, 14 years. What did I do? Nothing. 1 year, 14 years. Look at that. She started so happy about the implants. She started to brush so much that she's doing a cleft on this premolar. You see? But I don't care because my implants is fine. So no problem. Okay, but this will, and you can count on these 2 millimeters, which will stay. This is the base. People don't like to tell this too much, but it's good to being proud to say that you grow these 2 millimeters. But Mother Nature, if you're not too bad, did it. But if at the time of surgery, you compress, then papilla will not grow. So if you do a temporary crown, do a very specific shape, not to compress the papilla, which will grow anyway after. It means that success is a puzzle related with hard tissue and soft tissue manipulation, with positioning implant positioning, and precision in this positioning. So if you have all the parts of the puzzle together, then you'll get good success. But one class A, one class 1A, is also the site preservation technique, where you have extraction, you preserve the papilla, you place the implants, you preserve the site if you can, as much as you can, using the piezo and desmotome, and very careful when extracting. You can play as well with connective tissue graft when you need, and go to immediate temporization with no compression, where tissue will grow anywhere. Look at this case. She comes from the upper jaw, immediate loading. She has a removable denture. You can see this. She is going to start with the upper jaw and then the lower jaw. So we maintain temporary the lower jaw first, but we're speaking now on the upper jaw. Two things: narrow implants are a key for success. Less titanium, more bone. I use more than 60 to 70% of my implants are narrow implant, 3.5 to 3 millimeter diameter implants. And the other thing when you extract is to compact the biomaterial as much as you can around the implant. You need to compact. I've been the first 15 years ago to tell that you need to compact the biomaterial. And now more and more articles are starting to be shown telling that you need to compact the biomaterial if you want to keep the ridge around the implant with the age. So we can place the implants palatally, you see, and we're going to compact this biomaterial labially to preserve the ridge. And if you preserve the ridge, aesthetic will stay forever. Look how we place plants in the palatal side, preserving the alveolar carefully. As the shape we gave to the soft tissue, we check with your stel, we are orange, 68. Okay, so everything is fine. We are orange, also 65 or to 68, more than 70. We are on the safe side. Now we can go to the posterior implant and be okay. I'm using some biomaterial produced by osteobiol, which is the porcine biomaterial together with copolymer. And this biomaterial will become extremely hard. This is the future. Look at the soft tissue, my friend. I can augment the ridge by putting this dense tissue, this dense hard tissue, which is the biomaterial, mineral, 80%, 10%, 70%, 20% collagen, 10% the copolymer, which hardens the biomaterial immediately. Look at that. We place a bridge, but you have to understand, if you want to preserve the papilla, too much space, no papilla. Not enough space, no papilla. If one of your patients comes to your office with a diastema Will they have a papilla? Of course not. If you have two implants too much space, no papilla. Mother Nature tells you what to do. If two teeth are too close together, will you have a papilla? No way. So not enough space, no papilla. That's why precision in implant positioning is the key for success. So if you are not precise, look, papilla will disappear. No matter, you can expect if you have 1 millimeter to grow a 5 millimeter vertical papilla. No way. It's amazing because no one is thinking about that. But this is the real truth. Simple. It's too simple. If you optimize the placement as a result after 3 weeks, look at that. Tissue is there. Look at the quality and the shape and the texture, the color of the tissues using this kind of material. But you know, no compression with the temporary bridge, screw retain restoration, and look, the papilla is there. And when we'll have the definitive restoration, we'll get 2 more millimeters. Look at the precision in implant positioning, once again. And look at the healing. What I told you, this is after 1 week, we remove the suture, papilla. Just no compression, 2 months, papilla grows by itself. A little bit red there, but now it's going to be better. But look at the anatomy of the temporary restoration. Within 2 more months, we'll be able to do a wonderful restoration by doing nothing. Place, precision, biomaterial, preserve the tissues. So this is, look, with a higher, look at the papilla. It's growing now. Look at that. Here, there, everywhere. But now is a class 2B. Class 2B, more difficult. Because we have to analyze the smile line, the lip mobility, the white-pink aesthetics, and the need for aesthetics. So this is the aesthetic analysis we should do every time. And the most important thing is the need for aesthetics. It's nice to have beautiful slides, but it's more important to please the patient. Some patients don't care. They don't show. They are not interested. So it's stupid to do too advanced surgery for patients who don't care. You just have to adapt the technique to the patient. This patient comes, she needed orthodontic treatment, and I asked her, and she said, you know what, I was in the country I was before, I got 7 years of orthodontic treatment. And she finished like that. So she didn't want to have any kind of orthodontic treatment. But the main problem to this patient is now she has this lateral incisor placed palatally, and the color, when she drinks tea, becomes there, and you have the illusion she has no teeth. So I sent her to the orthodontist because I wanted her to have an orthodontic treatment. And she came back and he said, you know what, this guy is very nice, but I don't want any treatment. I want an implant. I want quick. It's enough for me. Then I decided to extract the tooth, but I started to analyze the case. High lip line, high lip mobility, but look at that. Look at the, when I start to the right-hand side, I look to the left-hand side. Look at the angulation of this tooth. We should match both sides. Look at the papilla. We need to recreate the papilla. Look at the shadow, as I showed you to the previous case. The concavity, we need to think about that. And then we need to think about the overlap of this lateral incisor related with the cusp. Many things to think for a simple case. So we decided to place the implant, slightly labial, 2 to 3 millimeter apically from the CJ of the adjacent teeth, and I know that this will be fine. But then we can add connective tissue graft because we can add or biomaterial or connective tissue graft. We can take the tissue from the distal of the molars, with a distal wedge, a gingivectomy, palatal side, or a Bombay in edentulous zone. And we can control the suturing of our graft, which can be sutured there, here, or there, more or less coronal. We go to the palatal side, take some tissue, trim the tissue, very basic, nothing fancy, just what we've been taught to do, but suture the graft into the desired position. You see where we placed it. The several positions here, 1, 2, and 3. So soft tissue augmentation can be performed before, at the time, or after implant installation. It's what we did. We placed some biomaterial labially. We placed some connective tissue more coronally to match class 1A. We are almost in class 1A. And now it's no magic to obtain this kind of result. We do the papilla regeneration technique, taking tissue from the palatal side, semilunar bevel incision, like this, 90-degree rotation, and to fill the space with connective tissue between the implant and the adjacent tooth, like that. And now, this is what we could find. Not bad. Patient is extremely happy. With 1 surgery, to 2 surgery we did, look what we can get. But most importantly, what will happen with time? She has a highly planned, she's extremely happy now. Look at that. Because when she smiles, she's smiling like this. And when she's very happy, because she was very happy, she's smiling like that, which is the most terrible patients, which are the most terrible patients. Anything can be seen there. But look how happy she is. But time goes for everyone. 14 years ago, she looks a little bit tired. She's 14 years ago, more, as we are. Look a picture of yourself 14 years ago, you see the difference is the same for us. But look at what we got into the intraoral cavity. Same thing. No magic. Connective tissue graft, Papilla technique, optimal positioning. Time goes, 25 years ago. She looks better now because she's better in life. But the most important thing is the face change. But inside, she started like this, and she's better 25 years later than she used to be 25 years before. So when I speak on the technique, this is not just one case. You will see, this is thousands of cases, and reproducible technique. And if you look for the higher magnification, look at the tissue. Who could imagine there is an implant there? And the same thing, basic implant, basic crowns, no fancy. Of course, I use all the new techniques, but this helps me to be on the safe side. But we should never forget the basics. But when you lose more than 50% of the papilla, there are several techniques at second stage surgery, which can be tissue punch, horizontal flap, additional connective tissue graft, and socket engineering. Because we want, with the Papilla regeneration technique, to be able to reconstruct this kind of tissue between the implant and the tooth, to have a papilla-like formation. As you said, Omid, before, restoration of the interproximal papilla is one of the last frontiers to be addressed in aesthetics of the anterior implant restorations. And I fully agree with you. We want to have this kind of result, but he had thick tissue. But look at that. Who knows there will be an implant there? We want to have this kind of smile line with those 2 implants in lateral incisor, where she has a highly pline. We want to be able to do that. And the basic idea of a papilla regeneration technique is that the first incision to be performed on the palatal side. Because every patient in Tehran, Marseille, or Gothenburg have 4 to 6 to 7 millimeter thickness on the palatal side. Everyone. So if instead of taking tissue on the palate and adding there, take the tissue in the first flap to the palatal side, you will push it labially and you will get an excess of tissue. And this is a basic idea. Then you can do whatever, rotate tissue from the palatal, labial, everything. I'm going to give you the basic, But every time there is someone say, oh, I found a better ideas than Palacci, I turn from this side instead of this side. But I did everything. The only thing is I have nothing to sell. You can rotate everywhere. But I'm going to tell you what works, what is reliable. So you go to the palatal side. Because when you go to the palatal side, you get an excess of tissue. You will double the tissue, you see, in fact, which will be pushed labially. So that if you do the same thing, you will push an excess of tissue labially. When you place it, you do a scallop with semilunar bevel incision, and you rotate this tissue around this abutment like this. And you will have a wall of living connective tissue. But if the space is too narrow, no papilla. On the palatal side, and then from the labial side, you will, on the labial side, create the scallop anatomy, matching the normal anatomy, which is there. And you can see now from the palatal side, look, with this scallop anatomy, and the pleats you can see here will be the birth of the newly formed papilla. So, if you have an idea, you do your horizontal incision on the palatal side, like this. The more palatal you go, more tissue you'll get. Very easy. Full thickness flap, no fancy surgery. Full thickness flap to get access to the bone, get access to the implant, but you can do this technique whether you do a one-stage or two-stage surgery. No problem. The same thing. You just have to think before your surgery where you are going to do your incision. Look at the tissue here, extremely thick. When you place the healing abutment, temporary crown, if you go to immediate loading, but by pushing the tissue labially, you will get an excess of tissue on the labial side. Look at that. So now, if you close, you will be the reverse architecture, no papilla. But if you make your incision like this and rotate, like this and rotate, you will, the excess of tissue here will fill the space between abutments. And every time you do that, you will have an excess of tissue vertically, like that. It's why you can now reshape and create this scallop anatomy. I hope you all understand what I mean. I show you this again so that you understand exactly what we do. You can vary the position of the first incision, and you can vary the scallop and then bevel, the angulation of the bevel, when you make this kind of incision. And if you can do for 2 implants, you can do the same technique for 3, like this. And if you can do for 3, you can do full arch. And you don't need to add connective tissue, except in specific conditions. And this is anatomy you will get. Semilunar bevel incision, look at that. 5 millimeter. We are now 5 millimeter above the bone. And if you have blood supply, you'll get the papilla. This is why you are always ahead. Because now, after this 5 millimeter, which will be reduced to 4, you will get 2 more millimeters from Mother Nature, and you'll get a nice result. Very, very simple. Pedicle graft, you need to be very careful. You change the blade when you do it, because if you cut too much there, you cut the blood supply and bye-bye papilla. You don't cut enough, you will be tension, ischemia, and bye-bye papilla. So you need to practice a lot to be able to have this kind of overlap of the papilla above the bone. 5 millimeter, 4 millimeter. You see? Amazing. People say that when it's flat, you cannot get papilla. Then the suture should be a matrix suture. If there is a releasing incision, you start with a releasing incision and matrix suture above the papilla to hold the tissue in place, not through and through. Because if you go through and through, you will get ischemia, edema, and puff. Papilla will disappear as a soufflé, totally flat. So be careful of on the suture. Is a main thing. Look at that. Look at the perfect anatomy we got. 4 to 5 millimeters above the bone. And tissue will stay there where it is. If you have this space between the abutments, of course. Look at this. 2 teeth, 2 implants, full thickness flap, palatal side, remove the tissues, the cover screws, place the abutments, multi-unit abutments, and now we have an excess of tissue. And what can we do? Semi-lunar incision, rotation, papilla, rotation, and suture. Same thing. And I do this and again and again. So let's go back to 1992. I did this is in my first book published in 1995. Look at this case. 2 implants, enough space, the Papilla Technique, rotation, the plits, which is the birth of the newly formed papilla, and the gain of attached mucosa, the shape, and the 2 implants. Look at the healing. The shape of the papilla is here. Time goes, and look at that. We started at this level. By pushing the tissue labially with abutment, we have matched the normal anatomy. Now, look at that on a vertical. And if we do well, we will match in horizontal as well. 38 months. Look what we got. 48 months. Look what we got. 60 months. 60 months, 5 years. Look at the tissue there. We remove the crown just for the pictures. But more important, 1992, 2017, 25 years. We remove the bridge to show you that this is a real life and not a Photoshop technique or whatever you want. Look at the tissue and the papilla we could find 25 years later in very different anatomy, a molar and a premolar with the same basic aesthetic cone abutment and same restoration. So if you can do this for premolar and molar, you can do for incisors. And you have seen cases with incisors. Okay. But look, 28 years later, look at that. Tissue is still there. A little bit. We lost 1 millimeter. We lost 1 millimeter in 28 years. Not bad. Within 28 more years, we will 2 millimeters. Not joking, but you see, look at what we could get. Look at the anatomy 28 years later, better than it was before. Exactly as the same as the cases. And this is the patient now. She used to be a young woman. Now she's a grandmother with a white hair. And look about the tissue. She got some recession because she cleans a lot. She's happy with that, but she's extremely happy with the bridge, which is still there after 28 years. So everything is okay. Just a little movie to show you. We go to the palatal side, releasing incision, full thickness up. There was illusion the implant is closed, but it's just due to the camera. We place the abutments. We place the cover screws, and we have the excess of tissue. Look at that. Look at the tension there. So we go from distal to mesial. Rotation, like this, very, very careful there, because then you can cut the papilla and you push it and it should stay by itself. Look at the anatomy suddenly. Look, it's matching the premolar. And we do the same to the molar, like this, with a bevel angulation, very carefully. You see, very careful. You need to change the blades many times during these surgeries. Because if not, look, it's very easy to cut too much or not enough. So with the blade, you can control the tension like this. And now it stays by itself. You can do the matrix suture. and done. Finish, finito. Look at that. You already finish with the papilla. You take the impressions, you do the definitive crown with a beautiful anatomy, everything will be there. And we gain labially, look at that. And look at the shape we got, and we do the same on the other side. Some people say that with a thin biotype, doesn't work. No, we change the biotype. We take from the palatal side, we got nice tissue. This is the case with 2 implants, 3 teeth, 1989. Okay? Careful, breathe, slowly, look at that. 31 years later, what do you see? Same. Same, because they clean in a good way, the optimal placement, and tissue stays. Tissue is even better now, 31 years later than it used to be. And if you do this in upper jaw, you can do it in the lower jaw. Of course, you don't have always so much tissue, but it shows you that if you have nice tissue, you can have beautiful results. You can do, of course, a connective tissue graft there if you want to augment the reach. But I've seen so many connective tissue grafts placed for nothing. Patient can live with, and you take from the lingual, palatal, and then it will stay. Look at that. In the lingual side, you go to the lingual side with a bevel, even when you have just 2 millimeters of soft tissue, of connective tissue, you go around the tooth and you put tissue with a bevel. Look at that. And you can gain tissue. You place the abutments, this, and everything is nice. Look at the Papilla technique. Look at that. We got, by going to the lingual side, we got enough tissue to do there. You see? First papilla and the second one. Look at the excess of we could get in a very thin tissue ridge. We trim into that carefully and we rotate. Now you can suture and it will be a success. Matrix suture, every time the same thing. Look at that. I did my first surgery in 1988. So I did my first surgery in 1988. And from 1988 to 2020, I performed over 10,000 surgery related with over 24,000 implants. It means that this technique, I have some experience with the technique first, and then it worked because I would be crazy to do 24,000 times the same thing if it didn't work. And it means that I've tried everything and I know that now what is functioning or not. So tissue augmentation is related with several factors: ridge shape, quality of tissues, quantity of tissues, positioning of the incisions, and the shape of the bevels. It means that, and according to the needs, which can be that you want to add tissue labially, create papillas, or have a combination, you can vary on these different factors. And this is all a combination. You see, exactly when you fly a plane, you pilot a plane, you see, you vary with the hands, the legs, and everything to be able to control. Yeah. And this is the same thing for this tissue. Okay, I wrote several books. First one in 1991, the second one, 2001, have been translated in now 10 languages, not 9. Another book together with immediate loading anesthetic. More than over 10 years ago. It means that everyone is speaking now on immediate loading, anesthetic, and guided surgery. We were together with Moise the first to write a book on guided surgery. Mm-hmm. So it means that I know what is guided surgery. And the most important for me was that P.I. Brennemark, in his Bible, asked me to write a whole chapter on aesthetics because he told me, Patrick, your Papilla technique is incredible. And I even do this for my amputees. And I want you to write a chapter in my Bible, so which was a tremendous honor for me. But you don't have to forget, just to remind you that you should think about hard tissue, because you need to recreate a hard tissue support for implant, a hard tissue support for soft tissue, in order to optimize implant stability, implant positioning, and optimize final aesthetic. So you need that. And if you see a case like this, this is 3.5 months after extraction and a graft. You will see compacting the biomaterial. How nice is the bone after 3.5 months? First, no magic, no membrane, just the biomaterial and cut. Look at that, after 3.5 months. But if you still look at the x-rays, it was nothing left. I just look at the x-ray. I just compact the biomaterial and wait, nothing. When you're re-entry, look at that. I change a difficult case in an easy case. But now I will be in class 1A. And I couldn't, if I place the implant the first time, even place the implant. And I would not have get this result. And so with a single papilla, single tooth, we can even go to immediate loading if you want there, because the bone is extremely dense. But carefully, we go to this bevel incision. You see like that. Rotate. And look at the papilla. And we trim the tissue again. On the other hand, avoid any tension. You see? No tension at the time of surgery. No tension. After, you can do tension. When tissue healed, you can compress the tissue. It will bleach, but it will stay. Through the papilla, inside, outside, over the papilla. Look at that. Inside the palatal side, and we'll go above. And the papilla will stay. Look at that. You see? Simple, easy. But you see, we have changed a difficult case in one easy case. And the tissue is there. And you can see after 1 week, here, there. Look at the papilla we got. 1 week. Do you need temporary crown, everything? Of course, we did for temporary crown for immediate loading, but we don't, tissue is there. You see, and even when we grow, look at that. Look, the papilla was there, and after the crown, we got just 2 millimeters. We have no papilla, distal 2 millimeters. And we promote the mesial papilla because when they smile, they always show the mesial papilla.
Yeah.
So now you can build the ridge with a pyramid with hard tissue, soft tissue, and precision. And the combination of everything makes that you will be successful. So it's not one papilla technique, it's an overall concept of simplicity. You see, all my surgery are simple. We go from the palatal then, and one surgery, if it's immediate loading, we can do the same. And we reduce. I don't do as many autogenous soft tissue grafts than I used to do before, because you can take the tissue from the palate, any patient. And if you take too much, there will be a secondary healing, so it's okay. Just a few words for our surgical courses, that we do surgical courses in Marseille, you see, together with Ulf Nanmark from Gothenburg. We have a screen, you see, there, and the patients are there, and they see a live surgery, and they see, as we are in an aquarium, doing the surgery, and people can enjoy everything. And we did so many lectures from participants from all over the world. It was really so much fun. And look at this little video. 1 minute.
I just said to a colleague this morning that I think it's the best money I've ever paid for anything around implants. And I go to many conferences every year, but this has been absolute highlight in the last few years.
So now we've got the perfect line, you see, and not one long tooth and shorter one, so no one will see that there will be an implant there. These people are a great experience, and it's interesting that to see that they still find something to learn. So when even you think it's over, there is always to learn. And the concept I want people to leave my center having in mind that they can change the practice and simplify the treatment, and even by simplifying the treatment, be able to treat more sophisticated cases.
Answered all the questions that I've been asking many people for many years. So it has been a most wonderful experience, and I cannot wait to go back to my practices and apply these things which I have learned over the last 2 days.
This was a group from South UK and Africa. We got people from Russia. We got people from everywhere. And you see, with Ulf, we're a little bit tired after surgery. We relax. And we have always a nice dinner together in a nice restaurant, which is now no restaurant, all closed. It's a change of life. And people used to go to Cassis, a beautiful village near Marseille, to enjoy the following days. This was a group from Russia, Siberia. They used to eat in a boat to see the Calanque, which is a national park near Marseille, beautiful place with a wonderful sea. This was in November. The water was ice, but these people were from Siberia, so for them was warm.
Yeah.
If you go from Tehran, I tell you, you don't swim.
No.
Okay. Can I finish with, I said the question was, when will be next course? We never know. But just I want to do, because it was such wonderful experience. Do you have five more minutes to finish with the case?
Yeah, sure.
Omid?
Yeah, sure. Good.
Okay, so wait. No problem. Look at that. Will be just to finish with one case to show you again that we have to think a lot. This beautiful little girl she was a dentist. She's still a dentist. And she was a student when she came to knock to my door. And she was beautiful, but the smile was not the best. And we needed to replace those two. Look at the level from there to here, and the occlusion. Of course, we needed to change the occlusion, do orthodontic treatment, and extract those teeth. This is what we did. But you know what? In 1991, I already knew that we needed connective tissue. So you say I don't want to do connective tissue with my technique, but I was the first to do them because I loved this kind of technique. And you see, by doing that at the time of extraction, we have a nice connective tissue surrounding, you see, about the future implants there. We changed anatomy and we were almost ready to place the implant. And in this case as well, we place the implant, do the Papilla technique, rotation, angle, suture, and look at the beautiful smile she could get. She's in my first book to show you that it was treated in 1991, really. You can see this picture in my first book. So she was very happy. Unless one day she came and I took some pictures to see, and I realized there was some reddish image there. And I didn't like that because I said, this is a future complication. I didn't know why. At this time, I didn't know why. Now I know. Because this was cemented restoration. And I think that some cement went there and induced a little bit of inflammation. Because we know that when we can lose implants from that. And that over 45% of the implant placed with cemented restoration have still cement beneath the soft tissue and prone to complications. That's why I love having screw-retained restorations. But at this time, I didn't know. So what did I do? Accurate, as I do, but I was frightened to lose this because go to this level, this would be a disaster. But I thought I did a connective tissue graft on this side, it was beautiful, and did one on this side. So why didn't do a sliding graft, do two releasing incision, slide the tissue to augment the connective tissue there. So this was my way of thinking at this time, 28 years ago. And everyone now is speaking, now being very big, fancy surgeon about sliding tissue, connective tissue graft. But I did this almost 30 years ago. I was the first to do that around implants, definitely. So I know what is connective tissue graft around implants. And this is what I did, some tissue, 2 incisions, slide the tissue and do some, look, the graft there, and we slide like this, the tissue to augment the connective tissue there. And after 10 days, tissue is beautiful. Dramatic change. I'm really happy for her now because I know we almost lost this tissue there. But now after 10 days is good. Time goes, 3 weeks, everything is there. We see the little scar, but tissue is nice, okay? And 10 years. You see the patient gets older. She's still a beautiful woman now. She's 1 child. She's a dentist. She has a practice. She sends me patients because she knows it's working well, but she's extremely happy. Time goes, 20 years later, she came. You can see the face. She said, Patrick, there is something now. My tooth is becoming very short. Look at that. What can you do? I don't like that. And I look, you know what, my friends, connective tissue graft works fine because with the time it will grow. And then 20 years later, instead of adding tissue, I had to remove tissue to get the optimal result. And I performed a gingivectomy, reshape this, very basic technique to reshape that after 20 years. Amazing, no? Everyone is speaking on counting on loss of soft tissue, loss of bone, and then I'm just speaking on gain of tissue. But this is a real life. So I did reshape that, and I redo new crowns with new abutment to enjoy the better technology. But you know, when I play the crown, I didn't play with a temporary. I just do a beautiful crown with a nice shape, and then have some bleeding, whitening of the tissue for 10, 15 minutes. If it's gone back after 15 minutes to pink, then it's okay. It means that the shape is fine, and you don't need to be too fancy kind of abutments on everything. It's so simple. You place the crown and it will be okay. If you don't trust me, look at that. 1991, okay? Look at how she looked. 2020. Look at that. Perfect. Nothing done. You see? 2020. Look at the sides. Plenty of beautiful tissue, extremely nice, healthy situation. And this is what I try to show you today, that if you respect Mother Nature, you do the same technique every day, you can have reliable success. But just I would like to end up with 2 minutes. First, when she came, 29 years later. She's still a beautiful woman. She has 2 daughters. But look at that. This comes now. Will I change since I did something 30 years ago? Change the implant. Say, I don't do releasing incision. Because there is a concavity, I go slightly palatal. I will add a little bit of biomaterial, but nothing's very special there. Okay? I will change the shape of implants because that's one even the company doesn't do anymore, but a lot of implants function well now. I have nothing to sell. Drill perfectly well. My guide, I still, you know what? I've been writing books on guided surgery, and I still use my little tools I developed to see who I am. But now, narrow implants, as I told you, parallel, little on the palatal side, close, and then the papilla, add a little bit of biomaterial labially, you see, to have a nice shape, everything I told you. Compact the biomaterial, close, and wait, because she had very thin, narrow ridge. And at second stage, I have this little patient like this with a beautiful smile. But you want to know something interesting? She's a daughter of this patient. She got the 2 lateral missing incisors, and she has another sister who got 2 lateral missing incisors. So it's a privilege to have treated the mother and the daughter. And when she came, she told me, Patrick, I want you to show me something. I said, what? Show me your hand. Show the hand. Okay, don't shake, so you can do surgery on my daughter. Okay, Omid. I enjoyed very much what we said, just to say that if we are here, everything is here because of this man of PI. He invented everything. We owe him everything. Every day I do surgery, think of this man, every day. Because this is the last movie I did from him when we were together. He died 4 months later. And he said that this is not a question of shareholders. It's a matter of intellectual doctors who try to do the best and try to give the back, the smiling part of the patient. And this is what we need. This is, everyone is starting to forget who was PI. Now people place a screw, they don't know who was PI. And he invented everything. So I would like just to end up my presentation to tell everyone, please respect this man. And on this little image, on the soft tissue, I thank you for everything.
Thank you so very much, Patrick. I truly have to say, I really enjoyed the presentation.
Okay. Now I hear.
Yeah, I truly enjoyed the presentation.
Thank you, Omid.
And you know, as you said, first of all, I have to say, you mentioned something that I really truly believe in that, but I think it's a good lesson for all of us, that don't do so many procedures on every patient. Look for patient's demand and then do complicated and advanced procedures on the patient. Because nowadays, so many people want to have a perfect picture for every single patient, you know. So that was a good lesson, at least for me, I believe, so for so many other people. And the way that you presented the cases, you know, with 20 to 30 years of follow-up, it really means something. You know, it's something unique, because in so many events, we usually see the follow-ups maximum up to 5 years, but up to 30 years and the stability of the outcome, it's something truly unique. So I'm really thanking for that, for this amazing presentation. And Patrick, because you know, you are—
Thank you for inviting me, really.
Thank you. You are really, truly among those practitioners that really worked on papilla formation, and you were pretty much successful on that, and your follow-ups shows everything. You know, in some of your patients, you treated 2 generations of the patients, you know, mother and daughter, and both with the same problem, and everything were stable. So in your technique, in papillary formation, when you rotate the papilla, this was my question since like 5-6 years ago, when I tried to do it routinely. When you rotate the papilla, is it important that that papilla adopted in between the 2 implants or implant and the tooth in a horizontal way, or is it okay if it's in a rotated way when you suture it? Should it be completely flat with the bone, or is it okay to be a little bit rotated? Because in your animations, I saw that when you rotate, it was not completely parallel to the bone. It was like oblique.
Above. Yeah, because you know what? If you have the, okay, look at that. It's a cylinder.
Yeah.
Okay.
Yeah.
If you take tissue from there.
Yeah.
And you take the tissue from here, and if you rotate, the space here is the same here because it's cylindrical.
Yeah.
So if you go in this level, you make the tissue here, you rotate, and you will always feel the space in between. Sometimes even you have too much. So you can, so as it's a cylinder, it will cover. If the more you cover, the less tension you have, the better result. If you cannot cover for some reason because it's thin and for the spacing, you have secondary healing from the palatal side. Okay, always try to go to the labial side, because labial side is very easy to rotate. If you want to rotate from the palatal side, tissue is very thick, and you need to do a very long bevel incision to be able to do a little bit. You will get tension and ischemia. So the basic idea would be to be on the labial side, because it's always flexible. But even do, if you cannot close and have excess of tissue here, you can do the papilla here, rotate. Oops. Sorry, I go back. Have the papilla here, rotate, and go to the palatal side and rotate a little bit, and you have a double papilla. You see, you can go from palatal and rotate a little bit. Yeah. But the thing is, the more you cover, the safer you are.
So, and you know, one more thing, because you mentioned in the time of second surgery that it's preferable to go from the palate and bring the tissue to the buccal, so we have enough tissue to be able to do the Papilla technique and bring the and make the papilla formation possible. So what about the cases in the mandible that we don't have enough tissue to rotate from either side? What's your suggestion in the cases in the mandible, especially in the posterior parts?
I showed you sometimes you can, sometimes you can't. If you can, if you go a little bit to the lingual with a bevel, you see, from lingual towards the bone, you can add a little bit with the tissue, a little bit of tissue. But of course, due to the anatomy, you cannot get the lingual side in the lower the same result that you got in the upper jaw. Mm-hmm. So it's always a combination. But sometimes, of course, you can do connective tissue prior to this surgery, was the time. But you know that connective tissue grafts in the posterior are eaten by the muscles.
Yeah.
You see, so it's very difficult to get a big band of keratinized tissue on the posterior. So sometimes it's a compromised situation.
Yeah, yeah. And Patrick, one more thing that I noticed in your presentation, you know, sometimes we don't have enough attached gingiva on the buccal. So practitioners tend to have their incision on the palate to bring the attached gingiva to the buccal. So in those specific cases, if they bring the tissue from the palate to the buccal, and then they cut it to bring the tissue between the implants, will it be a concern for, again, losing enough attached gingiva on the buccal, or is preferable to go more to the palate to bring more tissue to the buccal and be able to do the papilla formation at the same time? I mean, do you prefer to do it a stage, first make the attached gingiva? Yeah, go ahead.
No, I always try to do as minimum as I can. So I always try to do as minimum as I can. So it means that if I need to go more labial, if I need to gain attached gingiva on the labial side, I will do the same a little bit more to the palate and do 2 vertical releasing incision with a full and partial thickness flap to apically reposition the flap to gain attached gingiva. And then I got enough tissue to rotate.
Yeah.
But I have sutured my 2 sides in the position. Then I got enough tissue. If I do not get enough tissue, I can add connective tissue, as I said before, prior to, at the time of implant positioning, or after in a rescue surgery, as I showed you in the last case.
Yeah, yeah, absolutely right. And one more thing that you mentioned regarding the diameter of implants, that you mentioned that most of your implants are 3.0 or 3.5 millimeters. Are you doing it also in the posterior zone or only in the aesthetic zone? I mean, is your preference of narrow diameters is generally speaking, or only in the anterior zone, which is more aesthetic concern?
Thank you for the question. It's a very good question. 18 years ago, I started came with a 3.3 millimeter implant, designed for lateral incisors or lower teeth, okay, anterior teeth. And I started to think, at this time, doctors, dentists were placing wide implants, 5 to 6 millimeter diameter implants. And I saw that the result, and which you can see in the literature, that the result of these wide implants is lower than the regular implants. Why? Because we get more titanium than bone. It's why the tissue. If you have a 5 millimeter implant, you need to have a 8 millimeter thickness, thick ridge. Who has this?
Yeah.
In the lower jaw, sometimes you lose the bone. It's like this, and you have 2 millimeters, 4 millimeters. Okay, so it means that I started to think, if you have more bone, you will get better blood supply, and implants should stay longer. And if you do this, you may not get a problem because the implant will be surrounded by bone. And I started to place implants everywhere, everywhere. I truly say that everywhere. And I have a study on personal study. I didn't publish because I have no, I am a clinician. I'm not in university, you see, and the company, I don't care and they don't care. So even at this time told me you shouldn't show things like this because they were frightened that their implant break, and they didn't. But I have a study made on over 10 years with 4,000 implants with 0.36 failure rate, 0.36 on those implants. So they don't break. And I place in full arch. I have full arch with all 3.5 millimeters. The case I showed you with a full arch, 3.5 millimeter. All implants.
Yeah.
For single tooth and for single tooth. If you have a single tooth with a narrow ridge, you place a 4 millimeter, you have no bone at the level, and you lose bone to 2-3 millimeters around the implant. And if the implant is into bone, you will never break it. Fractures are not a problem.
And Patrick,
if you have a good system, of course, if you have a screw from a car.
Do you also recommend less than 3.5? Because some companies have 3.25 or 3.3 or 3.0. Do you also recommend the diameters less than 3.5 or not?
I've done a lot of 3.3 when I was using Brennermark implants, but they stopped them.
Yeah.
And then I'm using more 3.5 because it's what we can get. But at 3.0, I would really use them if I have several implants. If there is I would do a 3.0, but it's not. This represents 2-3%. 3.5 is good diameter for me.
Yeah. Thank you so much. And my final question, because I know your time is valuable and you shared a lot with us.
No question. My time is for you.
Thank you.
My time is for you. No problem.
My final question is regarding the choosing of the proper diameter of healing abutments, because some practitioners want to fill up the space after extraction, by choosing a wider diameter of healing abutment, or going with the customized healing abutment to completely heal the space. But I want to know your recommendation, because you talked about the respect to the soft tissue and providing more space for soft tissue formation. So do you recommend using narrow diameter healing abutments in all cases? Or, for example, in immediate implantation, do you recommend to go with the customized healing abutments? And is there any difference or not?
I think, I'm sorry to say, that whether you use a custom-made abutment or you do what I do with a basic healing abutment, as the end result doesn't make a change. You can make beautiful pictures. I've done that. But look at this case. I have 3 implants. I did regular basic healing abutments. The tissue is beautiful. I take the impression, and by compressing the crown, we'll have a beautiful result. Mm-hmm. So it's a different way. There is nothing wrong about having this kind of abutment. But as I said, today, if I can place healing abutment, I say the case to my patient, to the referring dentist, or we can go to immediate loading, or if I go to a multi-unit, I place them as soon as I can. And they take the impression and they do the crown, or they do the temporary crown without any specific thought. And the results I showed you are nice.
Yeah.
That's nice. So if you want to do it, if you are familiar with that, you're happy with it, do it. Several ways to go to success. But I found that being simple like this and just having some whitening of the tooth when you press them always help me to have good results.
Yeah.
And you save time.
Yeah.
Because you take the teeth from the bottle and you put it into the patient's mouth.
Yeah.
You see? So you don't have to come back and see. But a lot of nice doctors have shown beautiful cases with that. So I have nothing to criticize. It's just a way of working. And I respect all the ways of working as soon as they help the surgeon to get good results. Different ways to get a good result. But simplicity, I may end up with by simplicity is the ultimate sophistication.
Yeah. Yeah.
And the more simple you are, the more sophisticated you are.
Yeah.
You see? So I've shown you that you can be so simple that it works and the results are there. So you can get the same result being very sophisticated with very fancy abutment, implants, guided surgery, all the one with the computer I tried as well. But if you are able to place implant with a good connection of the brain and the hand, finito.
Yeah.
You can get good results.
Thank you so much.
Good lesson for, I would like.
Yeah, sure.
I want to show doctors that they can get good results having basic, simple surgeries. They don't need to be so fancy. They want to be fancy. They're happy with that. Fine. But today, with the COVID, we need patients to come, immediate loading, done, ciao, finish. They don't want to come to our office. They don't want to be infected. They don't want to get virus. The less come, the better it is. And this is a way to reduce, by reducing the connective tissue graft, reducing the complexity of surgeries, to reduce the appointments and the risk for contamination.
Absolutely right. Absolutely right. Patrick, I have to say that, as I said, I truly enjoyed every second talking with you. And thank you for sharing your valuable time and your
Me too, being with you.
Thank you. And your energy and your
my pleasure. My really pleasure.
Rights, and really looking forward to welcome you soon after this pandemic in Tehran. And really looking forward to that day.
Absolutely.
Yeah, it will be my pleasure. And I'm pretty sure.
We have to spend some time together and with real pleasure.
Yes. So thank you so much. Hats off, my friend.
I think here. Okay. Bye-bye.
Take care. Stay safe. Take care.
Bye.
Stay safe. God bless you. Bye-bye.
You too.
Thank you.
Okay. Bless you. Thank you.